Good morning, everyone. Welcome to the first of two webinars we have on behalf of the National Cancer Audit Collaborating Centre, that's NATCAN. I'm Professor Ajay Agarwal, and I am the Clinical Director for NATCAN. We've got 5 presentations this morning and a further 4 this afternoon, and we hope you can join for both. Essentially at NATCAN, we review and try and understand the variation in care for cancer across the diagnosis and treatment pathways. We're 10 audits but cover 9 cancers. That's because the breast cancer audit covers both primary breast cancer and metastatic breast cancer. Specifically, we look across diagnostic performance, treatment, survivorship, but also issues of timeliness of care and also data and staffing. Next slide, please. We've got a thorough agenda for you today. We're going to start off with the National Prostate Cancer Audit. Each talk is roughly 15 minutes, and then move on to the bowel cancer audit, kidney cancer audit, ovarian cancer audit, and the non-Hodgkin's lymphoma audit, as you can see. And then we're joined by an established panel representing NHS England, the Health Quality Improvement Partnership, CRUK, and the National Data Registration Service. There are apologies from Frank Burrows, our patient lead for the National Hodgkin's lymphoma, who can't make it. Next slide, please. The event itself is completely dependent on yourselves to ask the necessary questions. We have a Q&A. Please do put those questions in the conversation. I'll be posing questions for roughly 4 or 5 minutes after each of the individual talks. Again, there's a huge amount of information in the talks. We have summarized those, but please refer to our actual website, the NATCAN website, for more detail of the actual State of the Nation reports, which we'll be presenting, and also a deep dive into the data itself. And we'll keep that conversation going, and then we'll have the panelists for 20 minutes. As I mentioned who the panelists are, please do forward any questions that you may have, and I will pose that to our panel. Otherwise, we hope you enjoy it. This is being recorded, so you will be able to access the actual presentation at a later date, which we'll have up on our website. If there are any questions that come from this afterwards, please do email either the individual audits or NATCAN, and be very happy to answer those. This is our opportunity to work together to improving patient care in the NHS for cancer. So thank you very much. I'll start off by asking Arjun Nathan, the Clinical Fellow for the National Prostate Cancer Audit, to join us on screen and to begin the presentation on behalf of their report. Thank you very much, Arjun.
Thanks, Ajay, and good morning, everyone. I'm Arjun Nathan, and I'm delighted to present the 2025 State of the Nation report on behalf of the National Prostate Cancer Audit team. Today, I'm going to focus on diagnostic trends, the metastatic presentation, and our key performance indicators aimed at improving prostate cancer care across England and Wales. Further, I'm going to discuss our new performance indicator that reflects how we're treating men who present with newly diagnosed metastatic hormone-sensitive prostate cancer. Next slide, please. So starting with diagnoses overall, in England, we've seen a 9% increase in new prostate cancer diagnoses from about 53,000 in 2023 to over 58,000 in 2024. It's now the most common cancer in England. And for the first time, we anticipate the number of diagnoses across England and Wales to exceed 60,000 in a single year when we get the Wales data. Just click for me there. Yeah. And overall, this rise reflects increased detection and awareness, but it also puts significant pressure on diagnostic and treatment pathways, which we do need to address. Next slide. So we're going to move on to metastatic disease and men who present with metastatic disease. We know that not all prostate cancer is the same. Some men are diagnosed with low-level prostate cancer, low-risk prostate cancer, which may never affect them in their lifetime. But on the other end of the spectrum, some men are diagnosed with very aggressive cancer, and metastatic disease represents that type of cancer. Now, these men do suffer from very poor survival outcomes, and it's approximated that they can survive for only up to 3 to 5 years. Now, overall, in this year's report, we report that the proportion of men who are diagnosed with metastatic prostate cancer has decreased from 17% in 2021 to 12% in 2022. Now, whilst that does seem encouraging and as if things are going in the right direction, this drop in the proportion is primarily driven by more men being diagnosed earlier with non-metastatic disease than an actual substantial fall in the absolute number of men being diagnosed with metastatic disease. And you can see that quite clearly on this graph here. The blue boxes are men who are diagnosed with non-metastatic disease. And you can see that year on year, that number has gone up. The orange box are men that are diagnosed with metastatic disease. And you can see that that stayed the same year on year. So we're not actually reducing the number of men that are being diagnosed with metastatic disease. And that's something that, we need to aim to do. Next slide. So moving on to our key performance indicators, this is how we evaluate the care across England and Wales and how we think we're doing in terms of managing prostate cancer. Now, performance indicator 1 is about the number of men, the proportion of men diagnosed with metastatic disease, and I've explained a little bit about why that proportion is reduced. Click there. And then next, we're going to move on to the proportion of men with low risk disease who are undergoing radical treatment. So we think of this as men who maybe don't have the most significant form of prostate cancer, but are potentially being overtreated. They're receiving treatment that they may not need, and therefore they may be subject to unnecessary side effects. We click there. And that's been stable year on year. That number has been around 6 to 7% of men who are being overtreated. What's possibly a little bit more worrying is that there's still significant variation amongst different trusts. For example, on the range, it can range from 1 to 40%. So there are certain trusts that are still overtreating certain patients, and that's something that we need to reduce. So whilst the overall number is good, we still need to work on the variation. And then performance indicator 3 looks at the proportion of men with high risk or locally advanced disease that are undergoing appropriate radical treatment. So these are men that actually do need radical treatment, and are we actually delivering that to them? And again, this performance has been pretty stable year on year, about 70%. Now, if we can move on. This year, we're delighted to report a new performance indicator for the audit. This is the number of men who are newly diagnosed with metastatic prostate cancer who receive treatment intensification therapy in the form of novel hormonal treatment or chemotherapy, or as I'm going to refer to them as SAT, which is systemic anti-cancer therapy. This is now the gold standard evidence base for these men. This is how these men should be proven. And this performance indicator is really key because it's a key measure of whether patients are actually receiving the modern evidence-based treatment that improves their survival. And overall for this indicator, we found a fairly poor performance, significantly poor in men who are aged 75 years and older, where only around 1 in 3 men are receiving the appropriate treatment. Next slide. So if we look into that performance indicator a little bit more, so these are men who have newly diagnosed with metastatic disease who should be receiving additional cancer treatment called SACT. Now, we've got 2 funnel plots, and whilst they might be slightly difficult at first glance to understand, I'm going to break them down and talk you through them. On the left, we've got a funnel plot for men aged 75 years and below, and on the right, we've got a funnel plot for men aged 75 years and above. And there is a thick black horizontal line running through those funnel plots, and that's the average. So that's across all the trusts. That's the kind of average performance which is reported in under 75 years as being 66% and over 75 years being 29%. And each dot is the performance of a specific SMDT, so a specific center that treats these patients. And what you can see here is overall, there is better performance for men who are younger and worse performance for men that are older, but there's still considerable variation in performance. So if you're diagnosed at one trust or versus another, you might have a 10% chance of receiving the appropriate therapy, or you might have an 87% chance of receiving the appropriate therapy based on how old you are and which trust you're diagnosed at. So that's the kind of improvement that we need to work on. Now, this specific performance indicator was subject to our outlier process. This is where we engage specifically in a 2-way mechanism with the trusts that are performing really poorly, and we allow them to clarify their results. We give them their data and they get back to us so that we can better understand why the performance might be low. And 2 things we found from that process is 1, we're not capturing all the data we should be. So trusts are coming back to us and saying, we are actually treating more men than you're picking up, and therefore our results aren't quite accurate. And 2, they're also saying, yes, there is a certain proportion of men which we don't know ourselves why we haven't given them the treatment. So it's an area that we still need to improve because our data and their data isn't quite correlating. And to make sure that we make this performance indicator as robust as possible in the future, we do need to improve the data quality. And the data issue and the otherwise poor performance is subject to our quality improvement initiative, which I'm going to discuss later. Next slide. So my colleague Joe Dodkins did some great work in a bit more depth on this subject. And she looked at the type of socio-demographic characteristics that make someone more or less likely to receive the appropriate treatment. And on the graph on the left, what you can see is the chances of you receiving SACT if you're diagnosed with metastatic disease based on your age. And whilst there does seem to be a sort of 75%, 3 out of 4 chance that if you're 40 to 50 years old, you're likely to receive the appropriate treatment, as soon as you get to men over 75 years of age, is where the red line is, there's a steep drop off, which suggests that there is a bit of a bias in terms of who actually receives the treatment. And we also found that not only are older men less likely to receive the treatment, but men from a black ethnicity are less likely to receive treatment than men from white ethnicity, and men from more socioeconomically deprived areas are less likely to receive the appropriate treatment than men from less socioeconomically deprived areas. So this fits in with a few other areas in prostate cancer which we need to improve. And those recommendations are very similar. Firstly, the treatment decisions, the treatments that we advise patients, the treatments that they undergo need to be based on their overall health and not just their age. That there is significant variation in terms of outcome and treatment across the country, and we need to know why that is and address that. And there is that inequality in terms of your ethnicity, in terms of your socioeconomic demographic level, and in terms of where you live in the country. And this is an area we think we can improve. And that's why we're going to use this as a basis to conduct our QI improvement. Next slide. So back to our performance indicators. So we also look at other things that are important in terms of overall prostate cancer care. And the first one is the number of patients who are readmitted after having radical prostate cancer surgery. So this is known as a prostatectomy. Click there. This result for this performance indicator has been stable year on year, which is reassuring. Click there again. And if we look at two known indicators that we've reported in the past, the number of men who undergo a urinary complication, so they have problems passing urine after their radical prostatectomy, and the number of men who have bowel or gastrointestinal issues after receiving radiotherapy, again, those results have been very similar year on year. It's about 6% in England. This year, we've also introduced a new indicator looking at this sort of area, which is to look at the proportion of men who undergo a urinary complication after having radiotherapy. And this result, so 6% for this year, is also very similar and in line with the results we've seen for urinary complications after surgery and gastrointestinal complications after radiotherapy. Next slide. Yeah. Next slide. So as I mentioned before, and I'm going to talk about in a bit more detail, that new performance indicator that we've introduced, looking at men who are newly diagnosed with metastatic prostate cancer, who should be receiving treatment intensification therapy in the form of SACT. We know that the performance isn't quite what we'd want it to be. It's not optimal. And when we want to understand why that is and try and improve that. So it's subject to our quality improvement intervention. The first step is something we've already completed, which was something I described before, where we looked at the lowest performing trusts and we worked with them to understand why their results weren't as good as they should have been. And we got 2 bits of feedback coming back to us. One was they thought they had treated these patients, but it wasn't coming up in our records. So there's a data issue there. There's a lack of correlation between what they're saying and what we're receiving. So that's an area we need to improve to make sure we're accurately capturing the men who are being treated with SACT. And the second part, which they did feedback, was there are some men who they don't know. They're not sure why these men didn't get it. It wasn't appropriately recorded. It wasn't appropriately documented, so they can't explain why. So it might have been because they felt, patients declined it, or that they felt that they were unfit for it. But again, as it wasn't recorded, we're not quite sure why. So we have an understanding of what the problem is. We don't think that we are completely fulfilling the clinical requirements and standard of care for these patients, but we also know there's a data issue. So we need to address both of those issues if we're going to see improvement. Now, the first thing that we're going to do is a webinar that we've got on the 23rd of October. That's going to look at the use of systemic anti-cancer treatment in metastatic prostate cancer. And that's going to try and address some of the common reasons why people don't get this drug. And that's because they think, or they're not prescribed these drugs by clinicians. And that's because there's a concern over the toxicity. They're not sure exactly how safely to prescribe it. and they're not sure what the sort of side effect profile might be. So we're going to try and educate our clinical population in terms of how we can best manage those issues and try and reassure them that it is safe and the evidence behind why it's so effective. Secondly, we'll also be working with trusts to help them appropriately collect and process their data so that what they're doing, we're seeing. And that's really important. And that's an issue, I think, that's not just singular to this audit, but might be reflected in other audits as well. And if you are interested in that first webinar and you'd like to know a little bit more from the clinical standpoint, the QR code is on screen and you can sign up to attend it. The third bit is sort of a continuous process. So once we've identified a couple of problems, we think we have a couple of solutions for them, but are we actually making a difference? And the way we're going to assess that is with continuous feedback. So feeding back to trusts, reassessing their performance and seeing if they're actually getting better. Can we actually create an improvement here? Next slide. So looking ahead for the future years for the prostate cancer audit, we are really keen to expand the audit with new indicators that reflect modern and very dynamically changing practice in prostate cancer and look at patient-centered outcomes. We want to study the impacts of different prostate cancer treatment outcomes, including various forms of radiotherapy, including sort of salvage radiotherapy or different forms of radiotherapy. And we also want to look at complications of prostate cancer, such as men who undergo kidney obstruction because of advanced prostate cancer or have skeletal-related events. And so that will be the focus over the next couple of years for the audit. Next slide. And finally, just to say a big thank you to the whole team, without whom this work wouldn't be possible. And just to finish off, I just draw your attention back to our QI educational webinar that we've got planned for the 23rd of October to sign up if you're interested. Thank you. That's all from me.
Fabulous, Arjun. That was covering a lot of depth there, huge amount of work from the National Prostate Cancer Audit, and importantly, a lot to do. We've had a couple of questions in the chat. So I think the first one really is particularly with regards to the SACT and treatment rates with systemic therapy. To what extent do we think patient choice factors in this? Do we have any information on how many patients were actually offered the treatment?
Yeah, so that's something that requires a really sort of deep delve into the data. So we get that from the outlier process. So trusts may come back to us and say, for the 30 patients where you said we haven't given SACT, 15 of them actually declined it. They didn't want it. That's patient choice. But what's really important, I think, in terms of improving, we don't want to improve that number because that's a patient decision. But what we want to improve is make sure that everyone is being offered the treatment and it's being appropriately documented if they choose to decline it. And there were some trusts who didn't know why the patient wasn't, being provided with that treatment. So that's the area that we need to improve.
Thanks, Arjun. As you said, the audit results provide the signal for local review of those results specifically. Just further on to that, though, you did show that the rates of treatment do fall in the sort of late 60s, early 70s. We've had a question around why 75 years of age was chosen as a cutoff specifically.
So probably two reasons. One is that's the sort of steepest gradient on the graph that at 75 years of age. And also, I think there might be an anecdotal clinical idea that, men above 75 are just going to be unhealthy. And therefore, that's the sort of, the age group where we won't look to treat them as aggressively anymore. And that's where we need to sort of get away from that. So it's just to show that, those kind of historical clinical thoughts of above a certain age and 75 being a sort of 75 80 being the sort of cutoff isn't appropriate anymore. We really need to look at overall health rather than age alone.
Yeah, especially because the huge bulk of the metastatic population are over 70 and over 75 specifically, and probably adds to the issue of randomized controlled trials where many of the standards of care don't have or have fewer patients of that age group, which is yet the real world patient population we need to manage. We've had one other good question, probably will be our final question, I think, time permitting. So to what extent are these results adjusted? You mentioned about age. There's a question around the use of frailty scoring. Maybe you want to just reflect on to what extent this is adjusted for comorbidities and Joanna Dodkin's work with regards to actually, are we seeing something that is an issue?
Yep, so it's a great paper. I probably should have linked to it as well, but basically the results are adjusted for age, frailty, ethnicity, socio-demographic level, region as well. So as much in terms of the quality of data we have, it has been adjusted for that. So we can be fairly confident, if not 100% confident, that there are some genuine trends that we need to address there.
Thanks very much, Arjun. Huge amount of data, huge amount of work. Please do look on the website for further information about the National Prostate Cancer Audit. Next up, we have the National Bowel Cancer Audit. Pleasure to invite Adil Rashid to speak on behalf of the National Bowel Cancer team.
Thank you very much. So my name's Adil, and I'll be presenting the key findings and recommendations from the National Bowel Cancer Audit State of the Nation reports. Next slide, please. Next slide, please. So in 2023, 37,730 people were diagnosed with bowel cancer across England and Wales. And the proportion of people who were diagnosed with early stage or more treatable cancer has increased from 39% in 2019 to 42% in 2023. And this may reflect increased uptake and expansion of the National Bowel Cancer Screening Programme, which is available to people aged 50 to 74. Next, please. The audit also highlighted an increased proportion of people aged 50 or under who are diagnosed with bowel cancer. This has increased from 6% to 8% and is in keeping with global trends. Next slide, please. National guidelines recommend that patients with bowel cancer should be supported by a clinical nurse specialist through their care pathway. However, data for this information is only available for 71% of patients in England and Wales. Reassuringly, for patients with this data item available, 93% are recorded as being seen and supported by a clinical nurse specialist. This forms the basis of our first recommendation, which is for providers to improve data completeness of key items in national cancer registration datasets. Next slide, please. As part of the assessment for patients with metastatic or stage 4 bowel cancer, national guidelines recommend that these patients should undergo genetic tumor profiling, and this is to help inform decisions around treatment. Despite these guidelines, between 2019 and 2021, only 66% of patients with metastatic bowel cancer underwent genetic tumor profiling. The audit highlighted variation based on age. For example, younger people were more likely to have a record of genetic tumor profiling, with 75.5% of people aged under 75 having a record of testing, compared to only 47.9% of people aged 75 years and older being tested. This forms the basis of our second recommendation, which is to ensure robust, sustainable pathways to provide timely genomic assessment where clinically appropriate. Next slide, please. Focusing on postoperative outcomes, over time, the audit highlights that 90-day mortality after surgery has improved from 3.1% in 2019 to 2.5% in 2023. Similarly, the proportion of patients with an unplanned 30-day return to theatre after surgery has reduced from 8% in 2019 to 6.8% in 2023. The proportion of patients with an unplanned 30-day readmission after surgery has slightly increased from 11% to 11.9%. However, this remains below our target of less than 15%. When focusing on performance of 30-day readmission after surgery, we identified 6 providers who are outliers, where their performance was outside of that expected of an average hospital. And these hospitals are undergoing outlier process to identify the reasons for this. National guidelines also recommend that providers caring for patients with rectal cancer should regularly undertake major rectal cancer operations. And in 2023, we found that 78% of hospitals perform 20 or more rectal cancer operations per year, which has been stable over time. Next slide, please. For patients with rectal cancer undergoing surgery, a common operation is an anterior resection. This is where part of the rectum containing the cancer is removed, and the two ends of the bowel are joined together. This joint is called an anastomosis. A potential complication of this type of surgery is an anastomotic leak, and this is where contents inside the bowel leak from the joint. This potential complication could be life-threatening, and to reduce the potential severity of this complication, these patients often receive a temporary stoma or ileostomy at the time of their major surgery. Guidelines recommend that once an anastomotic leak has been excluded, this temporary stoma should be reversed within 12 months. This is because an unclosed stoma can reduce a patient's quality of life and also comes with an increased risk of complications such as parostomal hernias and kidney injury. Prior to the COVID-19 pandemic, the audit highlighted that only 33% of patients still had their diverting ileostomy 18 months after the anterior resection. However, since then, performance has worsened, and in our latest report, we found that almost 4 in 10 patients still have their diverting ileostomy 18 months after surgery, with wide variation between providers, from 13% in the best performing hospital to 77% in the worst performing hospital. This is the basis of our next recommendation, which is to increase the proportion of people who have their ileostomy closed within 18 months of anterior resection, to support providers to identify system-level and patient-level drivers of variation, and also to encourage participation in local and national quality improvement initiatives. Based on these findings, the National Bowel Cancer Audit has launched the Close It Quick Collaborative in collaboration with the Royal College of Surgeons to support hospitals improve their performance in this area. Further information of this collaborative can be found on our website. Next slide, please. Focusing on oncological management, the latest report found that 66% of patients receive guideline-based adjuvant chemotherapy after surgery for stage 3 colon cancer. Although performance of this metric has improved over time on a national scale, we still observe variation between hospitals from 47% to 90%. When measuring uptake of chemotherapy, it's also important to measure potential unintended consequences, such as toxicity or side effects from chemotherapy. Within the audit, we've developed a performance indicator to identify patients who have an unplanned hospital admission due to a chemotherapy side effect, such as diarrhea or sepsis. We found that for patients undergoing surgery between 2021 and 2023, 1 in 5 patients have an unplanned readmission due to chemotherapy toxicity. This figure has remained stable over time, but we see a similar variation between hospitals, from 6% in the best performing hospital to 35% in the worst performing hospital. It's important to note that this metric is also risk adjusted for differences in patient characteristics, such as performance status and age. Next slide, please. This forms the basis of our next recommendation, which is for units with chemotherapy utilization following resection of stage 3 colon cancer below 55% to conduct individual patient analysis to review the rationale for not offering treatment against evidence-based guidelines. If the resulting findings identify underutilization, for providers to develop appropriate local action plans to increase rates of chemotherapy whilst maintaining low levels of severe toxicity. Action plans may include integration of geriatric expertise or rehabilitation into shared chemotherapy decision-making. Next slide, please. The audit also measures the proportion of patients who receive radiotherapy prior to rectal cancer surgery. This is focused on patients with stage 1 to stage 3 rectal cancer. Over time, in England and Wales, the proportion of patients receiving neoadjuvant radiotherapy has remained stable at 33%. However, we see wide variation between hospitals in the use of neoadjuvant radiotherapy, from 6% to 87%. As an audit, we want to understand the reason for this variation to help support hospitals optimize their outcomes. We recommend that cancer alliances and health boards develop standardized, evidence-based neoadjuvant treatment protocols based on high-quality radiological staging. So no matter which hospital you're treated in, you receive standardized treatment. Next slide, please. Finally, over time, the audit has identified improvements in 2-year overall survival after bowel cancer surgery. This reflects advances and progress in overall quality of care. However, we continue to see variation between hospitals from 73% to 95% and identified 2 hospitals as outliers who are currently undergoing the outlier process. Next slide, please. Finally, this talk was delivered on behalf of the National Bowel Cancer Audit team who have put together the report. Thank you.
Thank you very much, Adil. Extremely comprehensive. As mentioned, please do refer to the audit website for further details, both across the indicators, but also individual trusts. We have had a couple of questions. The first question I'm going to ask you actually relates to trends in diagnosis and patients being diagnosed with bowel cancer at an earlier age. 1, are you seeing that? And 2, do you adjust for that?
Yeah, so in the latest report, we found an increased number and proportion of patients diagnosed under 50. So over the past 2 years, this has increased from 6%, which is around 2,300 patients, to 8%, which is around 3,000 patients. And this reflects trends that we see in other countries. There's potential reasons for why this may be happening. It potentially may be linked to patient characteristics, such as smoking, diet, different lifestyle factors. There's also potential links to the changes in the microbiome that can lead to this finding. In terms of risk adjustment, all of our performance indicators focusing on clinical outcomes, so for example, 90-day mortality, 30-day readmission, toxicity, they are all adjusted for age, and age is modeled as a continuous variable.
Thanks, Adil. So there's another question around earlier stage of diagnosis and to what extent there's a variation still, even though it's improving across regions, and does it link in any way as to how people are presenting? For instance, we know that emergency admissions are associated with later stage, for instance, so that's from James Baker.
Yeah, so although we're seeing an increase in proportion of early stage diagnosis, we're not seeing that accompanied by a reduction in the proportion of patients presenting as an emergency. So over the past 4 or 5 years, the proportion has remained static at 20%, and this is despite seeing increases in screening uptake and early diagnosis. So it's surprising that we're not seeing that improvement.
Thanks, Adil. I was intrigued by the genomics work that's being done at the moment, and maybe it would be good to reflect that you would think there would be a variation across hospitals, but your suggestion was that there's a variation according to age. Was that variation in age seen in the same hospitals then? Is it a case of a hospital may well be sending all their patients under 75 for that testing, but not patients over 75? So we're seeing an inequality there. It would be great if you could comment on that, please.
So one of the caveats with the genomic testing is data submission. So at the moment, data is only available for hospitals in England. And we also found that around 75% of the hospitals have incomplete data submission. So we weren't able to report on a hospital level results for those hospitals. Because we only have data available for around 20% of the hospitals, we avoided reporting this at a hospital level just because it may not be fully representative of the whole country, which is why we looked at variation in patient characteristics such as age.
Thank you, Adil. So we look forward to further results in that regard. There's just a question around, variation in results. There's neoadjuvant that you're looking at as well for rectal cancer, and this question of frailty comes up. So a lot of our public academic work allied to the audit looks at those with a deep dive, but has there been any adjustment for frailty or looking at those factors in this? Yeah,
so it's important to note that the variation that we find may be still due to case mix differences. So although we do adjust for things like performance status, age, T stage, we don't currently adjust for frailty. The clinical frailty score is not something that is available in our data sets. There are surrogates that we can use, such as the SCARF index, but we're not currently using that, although it's something that we're looking to do in the future. So I guess the answer is yes, the differences may still be due to frailty, but as Arjun mentioned, as we undergo our outlier process, this is something that we receive from the hospitals when we're looking at reasons for why we have this variation.
Yeah, and I think adjusting for comorbidities and performance status and age is pretty powerful as well. So if there are any slipping through the net in regards to adjustment, it'll likely be small. Thank you very much, Adil. I'll let you be for the rest of your morning. So introducing the next talk, which is Tom Cowling, Senior Methodologist for the National Kidney Cancer Audits. Tom, please take it away.
Yep, so morning everyone. I'm Tom, speaking about the kidney cancer audit. We're going to be giving you a brief look at the State of the Nation report from 2025. So if we move on to the next slide, please. The report came out around a month ago now. We had 8 performance indicators that were over-reported for the 3 calendar years from 2020 to 2022, or a few more years from 2018 to 2022, depending on the sample sizes available for different indicators. And we were looking at the 2022 to 23 period for Wales due to data availability. So over the next 10 minutes or so, I'm going to focus on 5 indicators in particular, which were the basis of the 5 recommendations included in our State of the Nation report. So the first one is the percentage of people with a small kidney cancer. That's defined as a tumour less than 4 centimetres in size who have a biopsy. Second one is the percentage of people with a higher risk renal cell carcinoma whose radical nephrectomy is done within 31 days of their decision to treat. And that higher risk category is defined by the staging you see on the screen there, so T3 or T4, 10 centimetres size of a tumour or greater, or an N1 staging as well. The third one is looking at the percentage of people who have surgery in this T1b to 3NXM0 group. Fourth one's looking at the percentage of people with a T1a tumour, so a small tumour who undergo nephron sparing treatment as opposed to a radical nephrectomy. And the fifth one's looking at the percentage of people with metastatic renal cell carcinoma who receive systemic anti-cancer therapy, and that's defined as within 12 months of their diagnosis. So on the next slide, this is a generic results table from the annual report. Don't worry, I will talk through some of the details in a moment. I think if you click, yep, so there's the 5 indicators highlighted, which I'm going to talk through in a moment. So just to note, there are a few which I won't say any more about. So this is looking at percentage of patients who have a MDT meeting date recorded, one around clinical trial consent, which remains very low, and the percentage of people with kidney cancer receiving SAC to die within 30 days of starting it, which also remains very low. Okay, so let's move on to the first of the 5. So the first one is about biopsy. So it's the percentage of people with a small kidney cancer who have a biopsy. Just to note here that one limitation of this indicator is that we're only able to include patients who ultimately receive a cancer diagnosis. Ideally, we'd be looking at all patients with a small tumour of their kidney and looking at biopsy rates in that cohort as well. But because our data only includes patients with a cancer diagnosis, we have to look at something slightly different. So this percentage is relatively low at 20% nationally. And just to note there that there is quite a large range in practice here, so from 0 to 78%. I think this variation reflects some uncertainty or a lack of consensus around what best practice is. So the recommendation included in the report for this indicator is to increase the number of people with a small kidney cancer who receive a biopsy to confirm the histological diagnosis. And this recommendation aligns with the first guideline produced by the National Institute for Health and Care Excellence on kidney cancer. So part of that guideline is focusing on making sure that biopsy is offered at the right time to the right people. Hopefully, one impact of the guideline might be to increase this percentage and reduce the variation seen in it across providers as well. Okay, on to the next one, which is looking at the timeliness of surgery for higher risk renal cell carcinomas. So we've got this higher risk group here defined as the T3 or T4 or 10 centimeter plus or N1 group. And all of the patients included in this indicator have a radical nephrectomy. We're looking at the percentage of that cohort who have their nephrectomy within 31 days of the decision to treat versus later than 31 days. So this aligns with one of NHS England's cancer waiting times standards, which is to make sure that all patients receive their treatment within 31 days of the decision to treat. And the target for that is set nationally at 96%. As you can see for this group, the percentage is actually much lower at 68%. It's actually decreased quite considerably from 2019 to 2022. So it was around sort of 76% in 2019, and that trend is generally in line with what we've seen nationally across different cancer types for a decrease in surgical timeliness. Again, we do see quite a bit of variation between providers. The range there is from 29 to 100%. And this indicator is likely to be included in the quality standard that's accompanying the NICE guideline. So our recommendation down the bottom there is to review pathways for these patients to understand what's causing the delays and ensuring that providers prioritize this higher risk group over lower risk cases to make sure we're meeting national ambitions for treatment timeliness. Okay, the third one, if we move to the next slide, is about surgical treatment for the T1B to 3 NXM0 groups. So these are patients who you'd expect to be having some form of surgery, either nephron sparing surgery or a radical nephrectomy. And the time period we attach to this is between 1 month before, 12 months following diagnosis in our data. The percentage currently sits at 78% in England, 82% in Wales, again with some variation between providers. We'll need to do more exploration of variation in this indicator based on patient characteristics to ascertain whether this 78 to 82% is acceptable or reasonable or not, but that's how the percentage stands in our data. So the attached recommendation down the bottom there is to identify and address reasons why people in this group might not be considered for surgical treatment and increase the proportion of eligible people assessed and treated. Okay, number 4. So this is looking at percentage of people with small tumours, so T1A tumours who undergo nephron sparing treatment rather than a radical nephrectomy. which currently sits at 69% nationally, again with variation between providers. So our recommendation for this one is to make sure that these patients are discussed in specialist MDT meetings to support a consistent and appropriate consideration for nephron-sparing treatment, which can include thermal ablation as well as nephron-sparing surgery. Okay, and the fifth one is looking at the use of systemic anti-cancer therapy for patients with metastatic disease. So that currently sits at around 50% in both England and Wales. So we put this indicator into our outlier process this year, and we did find a few potential providers that, according to our data, weren't providing SACT in line with the national average, but this was later found to be due to data issues. So, and as you can see on the funnel plot there aren't any outliers outside the 99.8% control limits. So our recommendation is to ensure that people in this cohort are evaluated by a medical or clinical oncologist with the appropriate expertise. Okay, next slide. We do have a dashboard up and running, as the other audits do, so feel free to head to the site to look at different providers' results. And then the final slide is just to acknowledge the team. Thank you very much.
Thank you very much, Tom. Some very interesting results across quite a wide range of indicators, actually, everything from utilization of systemic therapy, appropriateness of biopsy, and importantly, treatment of the cancer with surgery. If I may, we haven't got any questions through the chat at the moment. We've got a couple of minutes. So just wanted to take you back to the biopsy of the small kidney lesions. When you have a variation between 10 and 80%, it suggests that the right answer is not that clear. Is that how can we clarify or move forward? I mean, we're reporting it at the moment. What is our expectation? Is low good? Is low bad? Is high good? Is high bad? What would you say we need to look for going forward?
Yeah, so I don't think it's necessarily for me to say as someone who isn't a clinician, but I guess it's for the NICE guideline committee to make these recommendations. And as I say, there is a chapter on biopsy in the guideline. One of the statements is clear about offering biopsy to patients who have a small tumor less than or equal to 4 centimeters, and there's exclusion criteria in there as well. So that guideline is now out for consultation. I think the closing date's 28th of October. So if there's anyone on the call listening who would like to input into the guideline, now's your chance to do it. But yeah, biopsy is also in the quality standard as well. So it seems like it's definitely going to be an area included and promoted. I'd say that's going to have resource implications as well. Providers need to be able to find the resources to start offering more biopsies if that is deemed to be the thing to do. I think there might be some uncertainty as to how to make those resources available at the moment, but I suppose that's the reason why we have these processes like the audit and the guideline in place, is to try and build the consensus first off and work from there.
There's probably a combination of the technicalities, the surveillance, use of scans, the ability to actually biopsy the lesion, particularly if they're small, and it could be something that's benign. So yeah, it is a complex area, and good that we're measuring that. There was just a quick question around the source of the treatment data itself, probably particularly for surgery and systemic therapy. We have about 30 seconds. If you don't mind just commenting on that, that would be great.
Sure. So the data on surgery comes from the hospital episode statistics admitted patient care dataset. So this is based on a submission that all providers are mandated to submit nationally. And then the systemic anti-cancer therapy data we draw both from the dedicated database, the Systemic Anti-Cancer Therapy dataset, as well as the National Cancer Waiting Times Monitoring dataset. We've done some validation between those two to make sure we're picking up as many records of those therapies as possible.
Thank you very much, Tom. Thank you to the whole team. Brilliant work. There's a question probably for you in the Q&A from Sue around maybe linking in with Grant and Amit about the future biopsy recommendation, if you don't mind answering, but thanks again.
Thank you.
So delighted to bring Georgia Zaku, who's going to be talking on behalf of the National Ovarian Cancer Audit. Georgia, you're up.
Great, thank you, Ajay. Hi, everybody. My name is Georgia Zaku, and I'm the Clinical Fellow for the National Ovarian Cancer Audit. And today, I'm delighted to present on behalf of the NATCAN team on our key findings and the recommendations of the State of the Nation Report 2025. Next slide, please. So the ovarian cancer pathway can be divided in the diagnostic pathway, the treatment pathway, and the survival outcomes. So I'll start with the diagnostic pathway, and we can see that there were 5,713 diagnoses of ovarian cancer in England in 2022, and 317 diagnoses of ovarian cancer in Wales in 2023. And focusing on this diagnostic pathway, our first indicator is around emergency admissions, and we can see that 40.1% in England and 41.3% in Wales of all the women diagnosed with ovarian cancer had an emergency admission in the 28 days prior to the diagnosis. And that number varied across the gynecological cancer systems from 30% all the way up to 52%. So our first recommendation aligns with our first performance indicator, and it's to reduce the current rate of emergency admissions by continuing to engage with the local populations to improve the recognition of ovarian cancer symptoms, particularly among older adults and those living in more deprived areas. But also we asked the gynecological cancer systems to review the cases of emergency admissions and try to identify potential missed opportunities and shared this learning with the primary care partners in order to support earlier diagnosis in the future. Next slide, please. Sorry, can you go to the previous slide? Yes, thank you. So our second performance indicator is around the receipt of treatment that these women receive, and that could be surgery or chemotherapy. So 61.3% in England and 71% in Wales of women diagnosed within 28 days of an emergency admission actually receive any treatment. And again, there is great variation across the gynecological cancer systems from 46 to 82%. And this variation can also be seen on the right-hand side on this funnel plot, where the horizontal line represents the average and each dot is a different gynecological cancer system. So looking at this indicator, we ask the gynecological cancer systems to investigate the results and aim to increase their performance. And one way is to engage with NOCA's quality improvement intervention, perform a detailed case note review locally, and assess the eligibility for treatment on the pre-admission fitness of these women and consider engaging with rehabilitation service early on. But also really important is the close collaboration within the gynecological cancer system. And I've been talking a lot about this gynecological cancer system, but what I mean is the cancer center with its surrounding cancer units. Next slide, please. And moving on to our third indicator. So if we look at the receipt of treatment, surgery or chemotherapy for women with stage 2 to 4 or unknown stage ovarian cancer, we can see that 74.2% of them in England and 80.3% of them in Wales actually receive any treatment. And again, the variation is from 62% all the way up to 88%. So our third recommendation is to review the performance, explore and address some of the reasons behind the variation across the gynecological cancer systems, performing a detailed case note review to identify reasons why women did not receive any treatment, but also document locally where treatment was actually offered to these women and the reasons for not treating these women. Next slide, please. And just looking at the platinum-based chemotherapy only, this indicator is available for England only. And we can see that 66% of women with stage 2 to 4 or unstaged epithelial ovarian cancer received platinum-based chemotherapy. And again, there was great variation from 45% all the way up to 84%. So our fourth recommendation is to try to identify opportunities to increase the utilization of chemotherapy, explore and address some of the reasons behind this variation. Again, performing a detailed case note review to identify reasons why women did not receive chemotherapy, document where treatment was offered and the reasons for not treating these women, and also assessing eligibility for treatment on the pre-admission fitness, and consider prehabilitation services for some of these women. Next slide, please. And moving on to the survival outcomes. So our fifth indicator is around 1 year survival. So 70.2% of women and 73.8% of women in Wales diagnosed with ovarian cancer survived at least 1 year after their diagnosis. And again, there is great variation in the unadjusted results from 58% all the way up to 87%. And we actually adjusted this indicator to account for possible difference in the case mix. And we can see the risk-adjusted results on this funnel plot on the right-hand side, where, I mean, some of this variation still exists. So our fifth recommendation is to review 1 year survival, explore and address some of the reasons behind the variation. So some of the reasons behind this variation could be differences in the treatment or in the diagnostic pathway. So we asked the gynecological cancer systems to take into account the performance of the previous indicators and try to identify key pressure points in the ovarian cancer care pathway. Next slide, please. And looking at 2 year survival, 57.8% of women in England and 67.6% of women in Wales survived at least 2 years after the diagnosis. And again, the variation was significant from 44.7% to 80.1% across the systems. Next slide, please. And I would also like to talk about the quality improvement interventions that we are launching in the National Ovarian Cancer Audit. And this is around our second performance indicator on the receipt of treatment for those who had an emergency admission prior to their diagnosis. Next slide, please. So yeah, we can see that on this funnel plot that there was great variation, but also more importantly, we can see at an ecological level that the systems who are providing more treatment for these women with an emergency admission prior to their diagnosis tend to also have better overall 1-year survival. And each of these dots is a different system, and the red line shows the positive correlation between receipt of treatment and 1-year survival, which is the utmost goal. And next slide, please. So we're going to be launching our quality improvement interventions in the next weeks, and we've already started engaging with the clinical community through webinars at the annual meeting, and by sharing our plans at the social media and the newsletters. So we'll be contacting all the clinical leads of the cancer systems, and we will be including a performance assessment with potential action plans, a short report, but also we'll ask them to come back to us with a response, by filling a response template with their proposed action plans and implementation timeline. We would also like to launch a national quality improvement initiative around this indicator, which will be called GOTCHI study, and this hopefully will be done in the next year or so. And my last slide, please. And this work would not have been possible without the contribution, hard work, and commitment of the whole team. And thank you very much. I'm very happy to take any questions.
Thank you, Georgia. Again, huge amount of detail in there, summarized extremely well. I'm just going to probably, just as we're waiting for questions in our chat, do you mind just talking a bit around the emergency admissions and that very stark variation we see in people having treatment? There are probably a number of different teams involved, a lot of diagnostic uncertainty. We have acute oncology, general medicine. What does this speak to? Where do we need to align better in the hospital itself when patients do present?
Thank you, Ajay. This is a really important question, and this is what we're trying to nail down. So there might be issues with when these women actually present to the hospital, and like getting them through the diagnostic pathway as quick as possible. So getting their diagnosis right from the beginning, and focusing on their prehabilitation, so getting them to their previous performance status, but also offering them chemotherapy, which is the main treatment for these women. So one possible action plan is actually having acute oncology service, ideally in every trust. So these women could be offered treatment as soon as possible, because we know that these women tend to deteriorate quite quickly. So if we don't intervene and offer them treatment as quickly as possible, the chance of them progressively become worse and worse is quite big. So yeah.
Thank you, Georgia. There's a question around, we've talked about the gynecological systems. There's a question from Kerry around the role of the Cancer Alliance and your quality improvement intervention. I know you've got a sort of bigger, more ambitious study, and then harnessing audit and feedback. Can you comment on that, please?
So we will be contacting the clinical leads of the gynecological cancer system, and each system is within an alliance. So, one way of dealing with that is the clinical leads liaising with their cancer alliance to try to identify ways of improving their performance. So the reason why we write to the clinical leads of the systems and not the alliances is that because some of the alliances have more than one cancer centers. So the clinical lead of the center has a better overview of what's happening across the cancer units in the cancer center.
Yeah, and they can oversee coordination. So I think, as with all things, communication up and down the sort of pathway is important. And I think Carrie's just added another important question, which is around, is there a national recommendation for an ascites pathway? People do present. Ascites is a very common presentation. Is it gastro? Is it gynae? Is it medical? Can you comment on that, please?
So we don't have an ascites pathway for secondary care, but this is something that we're looking into exploring, because we've seen that as well, that these women, the most likely presentation will be with an ascites to emergency to A&E. So we're looking at developing an ascites pathway. Yeah,
Thank you.
it's a very good recommendation.
Thank you, Georgia. There's some more questions suddenly coming, but we're out of
Yes.
time, I'm afraid. There's an excellent question from Jane around the role of GPs in earlier diagnosis, which you can respond to offline. But thank you again, the team, for a fabulous presentation. Thank you.
Thank you, Ajay.
So last but not by no means least, we have our non-Hodgkin's lymphoma audit presentation, which the senior methodologist, Kate Walker, will be doing. Kate, the floor is yours.
Thanks very much. Thanks, everybody. I'm Kate Walker, the Senior Methodologist for the non-Hodgkin lymphoma audit, and presenting on behalf of Ruhi Kanani, who's our clinical fellow, and she's gone off to have a baby. Next slide, please. So starting with diagnosis and staging part of the pathway, we had 15,433 patients diagnosed in 2022 with non-Hodgkin lymphoma in England and 729 diagnosed in Wales in 2023. They're the most recent years of data from gold standard cancer registry data available to us. For the first time this year, we've looked at the patients presenting in an emergency for non-Hodgkin lymphoma and found that this in England is 28% overall, with variation between trusts. Between 23 and 33% was the interquartile range for England. We are working to develop this indicator for Wales as well. And as a result of this, we made our first recommendation in our State of the Nation report that emergency presentations should be reduced, for example, by examining variation in rates of emergency presentation by geographies and by population groups to identify potential causes. There's a lot more work we need to do, I think, in the audit to try and understand what exactly is going on for which groups there. And then within the hospitals to review diagnostic pathways into and within secondary care to improve timely investigation. Next slide, please. So staying with diagnosis and staging, we report on the proportion of patients who saw a clinical nurse specialist. We do have an issue with data completeness here. So you can see that for England, only 40% of patients have this recorded at all. And within those, 83% within England were recorded as seeing a clinical nurse specialist. That was 96% for Wales. So clearly some data issues to work through there. Our indicator on MDT discussion within 4 weeks of diagnosis. Again, some issues with data completeness there, but not as bad, 72% data completeness for England. And what we're seeing is that 60% of patients in England were recorded as being discussed at MDT within 4 weeks, where that information has been recorded to us. We don't have that recorded in Wales. And we do see quite wide variation between trusts in England, with an interquartile range of between 51 and 72%. Next slide, please. Moving now on to treatment, we have a metric about the proportion of patients who start SACT within 62 days of referral. This is amongst patients with high-grade lymphoma. And you can see there that in England, only 55% of them are starting their SACT within 62 days. And for Wales, that's 48%. Again, wide variation between trusts, MDTs. We've got interquartile range of between 45 and 64% for England, between 35 and 56% for Wales. So this formed the second of our recommendations in our State of the Nation report, that there should be local review to identify delays and reduce variation between providers in this waiting time. This may include examination of delays along the diagnostic and treatment pathway, chemotherapy unit capacity and staffing, as well as mode of delivery of SACT. And I think that the audit does need to do more work to understand exactly where in the pathway these delays are occurring and in which particular groups of patients. Next slide, please. So this is about timing of radiotherapy following completion of first-line SACT, and our indicators that the radiotherapy should start within 8 weeks at the end of first-line SACT. We don't have this measure in Wales because we don't have the end date for the chemotherapy there. But in England, we found that of those having radiotherapy after SACT, 33% of them started within 8 weeks. Again, wide variation between providers, between 11% and 50% as the interquartile range there. Next, please. This is our third recommendation. So we identify we recommend that patient and hospital factors are identified that are contributing to these delays. We recommend exploring strategies to reduce variation across providers, which may include ensuring specialist representation at MDT meetings, earlier identification of appropriate candidates for radiotherapy, a review of radiotherapy unit capacity and staffing. Next slide, please. We have a new indicator this year's State of the Nation report on trial participation. From what we've been able to estimate so far, using the cancer waiting times data, we only have a record of 2% of patients with non-Hodgkin lymphoma who are recorded as having received any care as part of a clinical trial in England in 2022. Note that we do have issues with data quality here. Also, the audit does plan to do some more development work to see if we can get that information from other sources as well and triangulate that information. But we already do recommend that providers identify reasons why patients were not enrolled in trials to ensure equitable access. And we're also asking for improved record keeping of that enrolment in trials so that we can better audit that metric. Next slide, please. So on to the survival now of the pathway. We reported by subtype the 1 year and 2 year survival for England and 1 year survival for Wales. And this is our start of our outlier reporting in the non-Hodgkin lymphoma audit. So risk adjusted 1 year and 2 year survival has gone through the outlier process for the first time. We adjust for age, sex, stage, subtype, performance status, comorbidities, diagnosis route, diagnosis year, and obviously that relies on accurate risk factor measurement. So we really need improved data quality to be able to accurately risk adjust these. But the next point, please, on the slide, we did identify one positive outlier, so someone with higher than expected survival on 1 year risk adjusted survival. We did not identify so far any negative outliers, but as I say, we do need to be careful with our risk adjustment. Next slide, please. So this moves on to our final recommendation, which I keep mentioning the issue we are really encountering with this audit in particular, I would say, partly because it's a new audit, and I think also because of the issues particular to hematological cancers, we are having issues with data completeness. And you can see there, for example, that the staging information particularly does need improving. Next point, please. The recommendation, final one in our State of the Nation report, was to ensure that there is a designated coordinator or clinician in each MDT to improve completeness here, with a particular focus on staging in both England and Wales, and focus on treatment delivery in Wales. And as I say, as well as understanding variation in care and outcomes, it's also crucial to allow better risk adjustment and allow us to effectively outlier report. Next slide, please. This brings me on to the focus of our quality improvement intervention. We are focusing on improving data quality, because without that, we won't be able to accurately report about non-Hodgkin lymphoma care and improve care and outcomes for patients. The intervention has launched already. We had a webinar last week, and we have materials coming up on our website there will be the recording of our webinar, case studies of how improvements have been made in some trusts. So the intervention itself, as well as having our webinar, is a targeted feedback intervention, with bespoke feedback being sent to any trust in England with less than 50% completeness on Ann Arbor staging. England, because that's where we have our quarterly data dashboards, which can support the work. Please go to the NATCAN website, find this link to the data dashboards. Next slide, please. And you can see here that there is a really wide variation between providers, with some trusts managing to have excellent data completeness on Ann Arbor staging, even in the most recent data. And there's a lot we can learn from that, which we showed in our webinar last week. And we're really working to get the trusts at the right-hand end of that ranked bar chart shifted over to the left. We think there's real potential there. We can make some improvement. Final slide, please. Thank you to everyone in the non-Hodgkin lymphoma audit team, their pictures there, and especially thanks to our partners and chairs of our clinical reference group and our patient and public involvement forum. Thanks very much.
Thanks very much, Kate. So just waiting for some questions to come through. There is one question, but just before then, with regards to your quality improvement intervention, when are you expecting to go live with that?
So in the next 2 or 3 weeks, we'll be sending out emails to those trusts with less than 50% data completeness. But don't wait, have a look at our dashboards, have a look at our QI pages already to see things that you can do. We had some great ideas that came up in our webinar, quite simple things that you can do to improve the data completeness. So we'll be sharing those case studies as well on our QI pages.
Well, and also seeing that variation, it is something that should be improved at pace. And maybe you want to comment, as you said, it's a newer audit than what we found from other audits with regards to staging.
Yeah, absolutely. So I mean, I've worked on cancer audits for a long time, and what you can see, if you look at the established cancer audits, there is a much better improvement of data, particularly on things like staging, performance status. And I think really we have to carry on, we have to report, we have to do the outlier reporting we can, put the results out there on the dashboards, and then with the reporting we do tend to see that improvement in data completeness.
It's absolutely critical for our risk adjustment and also the subtypes as well of the lymphomas, many of which can be classified as a rarer disease. So there's a question around your clinical trial indicator, and is it right that you're using the cancer waiting times for that? There's a question whether that's the best source, or are there any thoughts as to other sources potentially that could be used?
Yeah, thank you for that question. It's a really good point. So this is our first time reporting it this year. We are continuing to develop that indicator. So we haven't reported it at individual trust.mdt for now because of that. I think what we do need to do is make use of the multiple sources of that information. So most of the trials for NHL are in SACT, so we can make use of SACT in terms of there's a flag in there to say whether it was part of a trial. We can also look at the regimens in SACT to see if they would be regimens only used as part of a trial. There's also an NIHR database which gives you the number of patients who are enrolled on each trials, so really rich data in there. So we need to triangulate across all the possible data sources for that.
Thanks, Kate. There's just a comment from Carl Walker around the changes to some of the databases, Somerset, for instance, and COSD, to facilitate the standardization of that process. And I think there's similar for a number of trusts. So I think it's just worth checking who that person is responsible within the trust, how is it done, and what's the flow from the MDT, really. But I think it's extremely important, and we hope for better results for next year. I think that draws us to a close for the individual presentations. Thank you very much, Kate, and to the rest of the team for a fabulous presentation and results, which are thought-provoking and provide guidance for local quality improvement. We're now at the stage where we invite my panel. So if we could have Nessa Tarabi, Danny Keenan, Dan Cariad, and Martine Baum. Once again, there is apologies from Frank Burrows, who was our patient representative on the non-Hodgkin's lymphoma audit, who's unable to join us. Thank you. Welcome, everyone. If we can just stop the share of the slides. Please do put any questions you have. You have all the people that we're interacting with as audits, multidimensional, multidisciplinary, all wanting to improve NHS care. I'm just going to go around and ask actually individuals just to introduce themselves to the audience, if that's okay. So if I start in terms of my screen with Nessa Tarabi, please, if you could go first.
Thanks, AJ. Yeah, so I'm Director of Evidence and Implementation at Cancer Research UK. So I'm responsible for our own internal evidence generation and all our engagement with the health service. And also previously, I was a Cancer Alliance Director as well, so have that perspective too.
Thank you. And that's Danny.
Hi, thanks again for the invitation. I'm Danny Keenan, I'm Medical Director at HQIP Commission on behalf of NHS England, as well as at DH, all of these audits. So I'm very happy to be here, and it's been a great presentation. So thanks again.
Dan.
Morning, I'm Dan Cariad. As you can see from my tasteful green screen background, I'm Deputy Director of the NHS Cancer Programme. So the process of commissioning and the audits from the NHS England end sort of sits within my portfolio of work. And we also run the treatment variation programme of work with the Cancer Alliances, which aims to take the work of the audit teams and try and support rapid improvement where we can across the country.
Thank you, Dan. And Martine.
Hi everyone, my name is Martine Baum. I'm Head of Data Projects for the National Disease Registration Service, or NDRS for short. And NDRS leads on the vast majority of curation of all the cancer routinely flowed data across the NHS that we make available to NATCAN for analysis. My team in particular does a number of things, but in particular relevance to today's call is that we lead on the collection and the quality assurance of that data coming in, including a data liaison function and NHS facing internal dashboards to support those quality improvement initiatives.
Thank you, Martine. There are a whole set of data questions that have come up, and you might see it on the Q&A as well, but I'll ask you specifically about that shortly. I just want to actually, we've had 5 presentations, a huge range of indicators that are presented, but important indicators that matter for patient care. I wanted to ask each of you what your reflections have been on in terms of what you've seen in areas that we really need to focus on. If I could start with Danny, please.
Yeah, so it's been really interesting, and there are a few themes coming. One theme is getting the results out to those who can make a difference, and another theme is timeliness of data. And this is a criticism that is made against most of the audits that we run. I think most of the data was coming out from 22 and maybe some 23. The criticism that we want real-time data now, we're not going to get to real-time data because we've got various blocks in the system that make that difficult. Nevertheless, kind of working with such data from 22, it's when you're going asking for money, getting things done, you say, oh, well, especially when you go to a trust comes back and says, oh, we've got our last year's data, it's much better than that, et cetera, et cetera. So the question really is, how can we collectively start moving to get data that's coming in I think we can leave real time to the side for a while because that's what everybody wants. But how do we get to a much more situation with much more timely data? And that's something that we could start working on all together. So that'd be the first reflection I would have on all of this. Great that it is. I'm not criticizing anything coming that we've heard here today, but how do we make it more timely?
No, it's a very fair point, and for our quality improvement interventions, we are using the rapid registration data set for precisely that reason, to look at the impact. I think data is going to be a major topic, but I'll come to that. So if I come to Dan, any thoughts or reflections from the results that you've seen?
Yes, I mean, as you would expect, Ajay, I'd steer us away from the data discussion, because I think, to me, the way that these data will improve over time is by people using them and attempting to make the clinical improvements or make the clinical investigations into areas there where we might be able to improve that the data imply, and that will uncover issues with the data. It will also uncover areas where people thought there might be issues with the data, but it turns out that actually there's a real underlying problem as well that they hadn't appreciated. And so my general steer to everyone, or plea to everyone, would be, don't assume the data are bad. You know, this is really the main key area of the cancer program and our sort of associated areas of work, where we are really focusing on the treatment that patients actually receive, not on early diagnosis, not on the operational performance and the waits to get them there. You know, are we actually giving people the best possible treatment once they are diagnosed and once they are being treated? And so, whilst there may well be underlying issues in the data, I think you know, that it's beholden on all of us and everyone to take it at face value, at least to start with. Start doing that investigative work to understand the potential causes of that variation. And sort of work through that process. And by all means, if we find there are issues with the data, then let's correct those and move on. But that would be my plea here, is like, let's really look at this as an exercise in clinical quality improvement, not primarily as data quality improvement, and have the data quality improvement as a positive externality, if you like, as a secondary benefit of trying to do the work around quality improvement.
Now, there's a very fair reflection, Dan, and obviously the audit programs have been going on for nearly 15 years plus. And whilst there can be teething issues, generally when we found a clinical issue, it's been identified and then improved. And that's why I think the outlier process is extremely important. So I suppose at one's peril, one ignores it, assuming that this is a data issue, because actually a huge amount is done in terms of trying to develop very unique indicators. I mean, I think we take for granted that we report on the radiotherapy data, the systemic therapy data. That's work that's taken 2 or 3 years just to develop methodologically to be able to show that variation and adjust, particularly for outcomes. So I think it's a point well made. Nasa, you look across different evidence streams. Your implementation is extremely important. What are your reflections from the results that you've seen?
So the national cancer audits continue to be an incredibly rich source of information, and it's certainly something that's a priority for me and CR UK to raise the profile of these audits. And my experience within the health system is that they didn't necessarily get the profile they deserved. And when I think about the league table that was produced by central government in the last couple of months or so, I wish that this one got the same attention. A few things really pop out for me, as usual. So something about the relationship between volume and performance is really unclear, and some of the kind of the traditional approach to improving by concentrating specialisms and things like that, you know, we need to review and think about that, and what exactly is the best approach to improving services, and also just how the NHS can respond to this kind of data and this kind of depth, and really the infrastructure that these results are going back into, because it's one thing to go back into the clinical leads of those services. Those are busy, and there's work that needs to be done to digest this information. The cancer alliances, I think, are really, really important in this context. But again, the infrastructure that most of them have created with regard to like clinical groups, usually tumor specific groups, sometimes modality specific groups across their patches is really important. And I think more attention that's paid to enabling local systems to respond to information like this, rather than perhaps identifying things that everyone should do, I think could be really, really powerful, and getting the right balance across those things. I mean, I could go on in terms of the interesting findings. I was looking at some of the ones I was thinking particularly with some of the ones in prostate cancer are so important about Black men and people from low socioeconomic groups and their experience here. And it really speaks to the importance of shared decision making about treatment and really making sure that patients get the time from their clinicians to discuss their treatment and make the best decisions for them. It's something that we find quite a lot, that people from low socioeconomic groups don't get access to the best care, don't have the best outcomes. It happens right across the pathway, although treatment is the focus of the audits usually. But I think the richness of this information should be a really great asset in trying to tackle some of those inequalities.
Thank you, Nasser. And Martine?
I just wanted to echo a couple of the points that were already made earlier. I think the value of the audit and of using that routinely collected data that is already flowing across the healthcare system, and there are, as you know, the data flows are mandated and the systems are in place. So by reducing that burden, by using data that's already in the system and using that to look at clinically relevant indicators is incredibly powerful. And we have had experience within NDRS, and I think NATCAN will do too, in terms of showing those indicators out to our audience, to our clinicians, to our trusts, and using them as a conversation starter to say, look, there seems to be perhaps an issue in this particular area about over-treatment, under-treatment, and then you can start that conversation and understand in terms of, is it a clinical, is it clinically acceptable that there is variation, which it might be? Was it a data quality issue, or is there anything else that's going on in the system? So I think this focus on the routine data and using it to put out clinically relevant questions, I think is incredibly important, and it will close that virtuous feedback loop of good data in, also equating then good indicators coming out.
No, absolutely, and concur. If there is a question though regarding the data and the flow and the process, there's some interesting questions around exception reports to support data completeness. I mean, on the ground, we had a number of questions last year for the State of the Nation reports. You know, if there is a concern around the data not flowing, it's obviously the responsibility of every trust to collect that data, and it is routine data that should be collected. That's the clear bit. The trusts are expected to collect this. This is not anyone else's responsibility. The NDRS is the data controller, and we process that data and create the indicators that people see. But Martine, if there are questions that come from this, what is the point of contact? It is something that I do get asked quite readily, and how should this process work?
Yeah, so we're quite keen to continue working with NATCAN colleagues on the data improvement initiatives, because as I mentioned before, we have a data liaison function in NDRS, and we have 8 regional data liaison managers who support the 8 regions that we have split the country to support the local trusts with their data submission. So we're always happy to work in partnership and to address some of the issues that might be coming out outside of the audit. So if you spot something in the audit, please let us know, because we can then look at that together.
Thank you, Martine. If you don't mind just popping into our Q&A contact for that, that would be great. When I think often people say, well, who do we contact specifically, or if there's a function that should happen in terms of the liaison in the 8 regions, that would be really helpful, I think, for people. Danny, so you've worked across many audits, not just cancer. I mean, do we have a cultural issue with quality improvement? Do people know what to do with this data? I mean, if we're still stuck on, is the data correct? Are we ever going to see the substantial improvements that, you know, we need to see?
Well, there are many aspects to this. There are problems with quality improvement because everybody thinks they know how to do it, and that's not necessarily the truth. Nevertheless, there is a lot of money and personnel going in to trusts for quality improvement work. And indeed, if you just take one example, which we looked at last year with the junior doctors, are all being asked to do projects every year to do with quality improvement. So, you know, there is a resource. It's not badly, not well used. So I think there is something across the board in terms of trying to get better at doing quality improvement. And I think that starts with getting the data back out to everybody. Like this idea of not getting get good completeness. If you go on the ground, probably not the only problem, but one of the problems is getting the data to those who actually put it in. So it's not a mindless task. It's actually they're getting something back out of it. So that's a really important point. How do we make sure, like in a sense today, we're just talking to the converted. How do we talk to the unconverted? How do we talk? And we're not just talking about students and like there are many consultants will say, oh, nobody told me about that. You know, you would think that there may be a remit to go and find that out, but that's not necessarily true. So how do we make sure that these results get right out to the front line? And it's not just the front line. For instance, recently we've been having discussions with changes in NHS England to the regional medical directors and the regional teams. They're not getting some of the results. One of them said, oh, I think that goes to my nursing director. You know, like, what's that all about? Like, how do we, like this, as somebody's already said, this is the most rich data. It's fantastic data. Like we're seeing variation all over the place, and that's the way it is in medicine, but we want to drive it out. So how do we get these results to those who can really make a difference? I think cancer actually has an advantage here because you've got the networks. Many of the audits are set up, but without a network. And how do we kind of capitalize on the networks getting the results, not just the network, but through the network on out to the front line. So that's and then you've got the substance for doing quality improvement. There's a lot of stuff already coming out today on quality improvement that's immediately obvious that could be worked on. So I think there's work to do, but it's out in the front line, I think. Thanks.
It's a very well made point, Danny, particularly that there is a requirement of trainees who are extremely talented and skilled to do quality improvement activity, but given a long list of internal priorities. And I think one of the benefits of the audits is that there is the feedback and it continues and you can see the impact of a quality improvement intervention. We've done the same within Guy's and St Thomas's and seen the benefit of the local quality improvement, so it does work. I'll bring in NASA.
Yeah, I just wanted to pick up on a point that the points that Danny was making about who receives these reports and who has the power to do something about them. So many of these things will be within the gift of individual clinical teams to do something about, but many of them require leadership across organizational boundaries and real challenge to the system sometimes, you know, and things like surgical rotas, and these are complicated topics that require top level leadership. And these are really important tools. And what we've seen over the past 10 years or so, unfortunately, is a reduction in the size of the teams at NHS England regional level in specialised commissioning. Danny mentioned regional medical directors. There used to be, well, I think there still are medical directors for specialised commissioning, but they used to be much better resourced, would launch projects, launch whole reviews off the back of data like this, sometimes from the audit, sometimes from Royal College reviews. And without that capacity, we run the risk of losing some of the benefits of having an integrated National Health Service. And we need to make sure we retain that. And that's something that certainly CR UK is pushing for, because we're in the process of devolving specialised commissioning down into ICBs, but that process has been thrown into some uncertainty recently, and we absolutely need to keep pushing that. The thing that is on the table is the quality improvement that is shown through these audits. You know, the difference, the unwarranted variation that's shown here. And I did just want to say one other thing, which is that there are kind of targets or notional targets that are within the audit. And I did want to commend that, because it's often really hard to agree a target or to agree anything that looks like a target when you're dealing with very complex clinical data that has to be case mix adjusted and all of that kind of thing. But the importance of still doing that and having the confidence to do that, driven by clinical expertise, I think is incredibly powerful as soon as it gets out of the clinical experts who need to look at it, because you need to be able to get this in front of a chief exec to say you have a problem that needs to be sorted out, or indeed you have something to celebrate as well.
Absolutely right. I'll come to you in a second, Dan. I just think feeding off on that, there is the need for behavioural change and a reflection of these results. So I think there are three aspects. I think the outlier process is long running, but you're looking at quite significant outliers, three times the average in terms of performance, good or bad. The second thing is we're working on audit and feedback. We do provide fantastic data. We've completely revamped our data repository and reporting platform, but actually you're right, not enough people are looking or seeing the data. So the audit and feedback literature is very much on active feedback and how we get the information to participants, because when it's seen and by the right people, it's normally acted on. I think third thing, the target setting is a challenge. So I think NHS England colleagues have very rightly asked about targets for a number of the indicators that we've had. This in itself has had very little positive or sort of academic precedent in the literature of how you do it. It normally results in people sitting around a table saying, well, we think it should be this percentage. The data doesn't tell us X or Y. Interestingly, the percentage that we have are very different because we do some benchmarking internationally from, say, Denmark or France, and you might argue that they may be in a different position from a cancer perspective than ourselves. So we are looking at a piece of work around how we can make a uniform and robust approach to target setting, because that does have an impact if we have an expectation. I'll bring you in, Dan.
Yeah, I was just going to comment on that too, because I think one of the things that we've been talking about and that I'm really interested to get feedback on from the attendees of this webinar is how do we make the audits more implementable, as sort of readily actionable as possible. There are some themes of things which have been raised before, so things like the timeliness of the data, the ability to sort of recreate the same metrics on the ground. Some of them are quite complex and draw from lots of different data sets, and that can be a challenge. And the sort of targets, or at least some sort of a guide level, or even in some cases all it needs is a sort of a directional guide. So you've got this kind of distribution of providers, and even just knowing whether you should sort of generally be aiming to coalesce around the sort of the top, the bottom, or in the middle of this distribution can be helpful. It doesn't even need to be a specific percentage, but I think all of these things are things which can help kind of close that gap between the sort of pure data that the audit is providing and the recommendations that fall out of that, and practice as it is, and the ability to change practice in everybody's kind of extremely obviously busy day-to-day, week-to-week clinical lives of clinical practice. So I think there's definitely, look, I definitely think we need a behavioral commitment to taking these audits and using them for the purpose intended, and for people to really lean into that. As I said earlier, I think that's obviously really important. I think it's a two-way street though, isn't it? I think we also need to be constantly looking at, okay, well, what are the barriers in what we've produced that mean that people actually aren't able to make progress with it, and how do we kind of support people over those hurdles, either through the audit itself or through the support that we provide around the audits through our program, through the Cancer Alliances, or whatever other mechanism it might be.
Dan, if you could just very briefly talk on the support that you provide through your program at the Cancer Alliances. I do think that's important, because clinicians do look at it, think, who am I going to get to help or support this, but actually are not aware that there's a completely integrated structure within the alliances. So do you mind just commenting to that, please? Yeah,
absolutely. So I think some people will be aware of this, others will be completely unaware. Some of you might even run these organizations, so I won't go into too much detail, but obviously we have a network of 20 cancer alliances across the country. It's kind of vary in size, from covering the entirety of the east of England to just sort of north central London ICB. So quite a range. But what we do is we take the audit reports each year. We work to try and identify what we think is the most treatment quality relevant indicator from each audit as far as possible. So sorry, that sounds slightly tortured, but as I was saying earlier, you know, we do have a large program of work around early diagnosis. We've got obviously a large program of work around operational performance and the waiting time standards. So for us in the national program, the sort of USP of the audit is focusing in on that variation in access to the best quality treatment, or to what people should consider the gold standard of care. And so what we have tried to do over the last couple of years is take from each audit one of those recommendations and say, you know, this is the kind of biggest impact treatment focused recommendation, and that's what we want everybody to focus on from within that audit. We then take, I mean, it's very similar to the sort of outlier approach. We take it depends on the metric actually, because some of them sort of break down in a slightly different way. But what we try and do is use the NATCAN data to highlight the worst performing providers or the biggest outliers. We work with the Cancer Alliances to say, here's your sort of list of providers that are not currently kind of coming up to the mark, or that we've got concerns about based on the audit data for each metric. And we want this to form the sort of core of your work program. There is some flexibility around that, because some Cancer Alliances happen to have a lot of providers that perhaps in more difficulty than others. So it's not a hard and fast rule, but that's the kind of starting point, and the Cancer Alliances then put together their program of work around what we call our treatment variation program on that basis. So that then the Cancer Alliances are funded to do some work in this area. They obviously have their clinical networks that they would work through. And the idea is really that they can provide that sort of overarching program management approach. They have analytical teams that can support that kind of feedback loop of data back to us in the national team, and ultimately back to NATCAN. And the hope is that whole framework just provides, you know, an extra bit of direction and on the ground support for actually consistently implementing the findings of these audits over time. I would be the very last person to claim this was a perfect process, but you know, we are trying to make sure that we've got a very clear sort of chain from the audit being published itself all the way down to something different happening for a patient in a clinic, and a clinician understanding better, you know, this is how I can help this patient, which ultimately is what this is all about and what it all boils down to. So it's all about trying to connect up the links of that chain.
Thanks very much, Dan. That was important, because I think there's probably not the awareness that we're working together. And I was going to bring you in finally, Martine, just to reassure people that the left hand and the right hand are talking to each other. They're part of the same body, and that we work very closely together. Do you have any final words before we close?
No, just to say that I think it is important that we do continue to work closely together, because of course we're part of the same organisation, but we do have slightly different areas of focus. But it's very important that SotN Cancer Programme and us come together and then work very closely with NATCAN and the Royal College to support the delivery of those audits, and that we do get that virtuous feedback loop between clinically relevant indicators and good data going back into the system.
Thank you very much, Martine. Thank you very much to all of you. Thank you very much to all the speakers. I've very much appreciated the comments that we've had in the conversation and the chat. We've tried to respond to most of them. We'll continue to respond. Please do realise that for each audit, we have the bespoke website, we have the methodology supplements. You've seen the contact details that we've provided for the National Data Registration Service as well. Just a quick thank you to Julie Noster, Verity Walker, Aurelia Chan, Fani and Sugiti Sukumar for all the work behind the scenes and keeping everything operational. They're behind me at the moment, scurrying away, but this wouldn't have been possible without them. The actual recording will be online soon, both on our website and the slides available. So please do keep in contact, and thank you very much for your attention. Very best.
Cheers. Thanks.